Hello everyone. We are all back of stress and we tend to forget about relaxing, and the same thing happens with, so we just tend to fall behind the systolic function and tend to neglect the diastolic aspect of the heart. So now let's sit back and consider a few aspects regarding the relaxation of the heart, that is diastology, and its implication in the perioperative period. So it was first described by Lucci et al. In 1982. LV diastolic dysfunction is described as an inability of an LV chamber to fill up at low atrial pressures. This can be considered like this. Now, whenever you are trying to blow a very stiff balloon, the pressure transmit back into your cheeks. You can feel that into your cheeks, and then sometimes it can transmit back into the lungs. So this analogy can be applied to the diastolic dysfunction. The balloon can be considered as LV, the cheeks can be considered as LA, and the lungs as lungs as well. So it is basically an alteration in LV relaxation, which is an active process, or an impairment in the LV compliance, which is a passive process. So by definition, LV diastolic dysfunction refers to abnormalities of diastolic distensibility, filling or relaxation, regardless of whether LVF is normal or abnormal and whether the patient is symptomatic or not. If the signs and symptoms of congestive heart failure, that is like effort intolerance, dyspnea, pulmonary edema, develop in such patient with normal or near normal systolic function, it is appropriate to classify the situation as diastolic heart failure. So why it is significant? So it is now established that diastolic dysfunction or diastolic heart failure 50% of the contributes to 50% of the patient with congestive heart failure having a normal systolic function. There is an increase in 30-day mortality and long-term morbidity and mortality in this patient, and the mortality was seen up to 4 times corresponding to the normal population. And whenever the patient is having a normal systolic function, but you still find to difficult to wean that patient from cardiopulmonary bypass or ventilator, always this can be the background cause. So what is the epidemiology? It is mainly found in women, which is up to 70%, and prevalence increases with age. In more than 70 years, the incidence goes up to 70%. So basically with age it is associated with CAD, hypertension, HOCM, all can cause some structural changes in LV leading to diastolic dysfunction. So let's just understand the basic diagram which we are going through since years. So basically the diastolic part of it, if you consider, it has 4 phases. The first phase is isovolumetric relaxation, the second phase is a rapid filling, the third phase is diastasis, and the fourth phase is atrial systole. So coming to the first phase, that is isovolumetric relaxation. It starts from the closure of aortic valve till the opening of the mitral valve. So and then next, coming to the rapid filling phase, basically it's a suction force. It is the suction force of the LV which opens up and allows the blood to flow in this phase. And the next is the diastasis, where the left atrial pressure and left ventricular pressure gradient become equal, and there is a diastasis. And finally the atrial contraction, where there is an increased pressure in the left atrium than the left ventricle, causing that push. Ideally, this atrial contraction contributes to around 15 to 20% in normal patient, but whenever there is diastolic dysfunction, that whenever there is a compliance issue, then this contributes hugely up to 40%. So these are the parameters which influence these phases. In isovolumetric relaxation, basically it's an active LV relaxation elimination process. Any process hindering it can affect this phase. Then in rapid filling phase, it depends basically on the LA-LV pressure gradient, the LA volume, the LV suction force, and elastic recoil. And whereas coming to the third and the fourth phases basically depends on the LV compliance, LA compliance, the pericardial constraint, and heart rate, rhythm, synchrony, AV synchrony. These are all the factors which influence these phases. So what are the broad causes? Active diastolic dysfunction can be due to MI, hypertension, HOCM, or aortic stenosis. Passive diastolic dysfunction can be a progression from this impaired relaxation, that is this active part, and then it can be due to some kind of infiltrative causes and some causing myocardial fibrosis. So basically, if you see the pressure volume loops of this patients with diastolic dysfunction due to various causes, there is first as you see in the figure A, there is a slow or incomplete myocardial relaxation as seen in MI, hypertrophied hearts, whereas in figure B you can see the pericardial constraint, and then in figure C you can see the impaired peak LV filling rate. So there is an elevated LV pressure leading to compliance and inability to generate the LV suction, and finally the altered elasticity where the neurohumeral responses which are initiating myocardial fibrosis. So whatever it is, the net effect of all this pathological process leads to a higher left ventricular end diastolic pressure for any given volume. So here there is higher pressure for any given volume. That is what the important aspect of this diastolic dysfunction. So if you take up the stages of the diastolic dysfunction, stage 0 is considered normal, whereas if you stage 1 is the abnormal relaxation, stage 2 is a pseudo-normal phase, and stage 3 is the restrictive, which can be further classified as reversible and irreversible. So coming the basic issues in these phases are, like in phase 1 there is a delayed pressure equilibration between LA and LV. So less filling occurs during the early diastole. So obviously there is a more filling with the atrial kick in these patients. Next is a pseudo-normal phase where there is impaired filling and increased left atrial pressure, but the compliance of LV is normal. So this is what is important: increased left atrial pressure with normal LV compliance. So this normalization here, the underlying relaxation abnormality is masked by increased left atrial pressure. So whenever you are doing some maneuvers reducing the left atrial pressure, this will unmask the relaxation abnormality. So the stage 2 can be shown as stage 1 whenever you are doing some maneuver which is going to unmask or reduce the left atrial pressure. And finally the stage 3, here there is a compliance change. There is an LV remodeling occurring. There is an increased left ventricular end diastolic pressure and increased left atrial pressure with rapid equilibration. So there is an increased early filling, shortened filling phase, and even there is limited filling with the atrial kick during this phase. So what are the sequelae of increased LA pressures? Ultimately the LA volume increases, pulmonary hypertension develops, RV diastolic volume overload occurs, and there is an increased TR velocity. So how does this patient present? Usually it is non-specific. They are only presented whenever the patients are subjected to some amount of stress, that is either exercise or during the perioperative period. Whenever you are giving some stress to them, they present. Otherwise, in the later on stages, patient can present with dyspnea on exertion and can present with pulmonary edema, with pedal edema and fatigue. So this is all non-specific clinical features in this patient. So the basic evaluation in the intraoperative period, we usually do it by trans-esophageal echo. So I'll be going through a few important parameters to be considered in the trans-esophageal echo. So basically the trans-esophageal echo, ideally to evaluate the diastolic dysfunction, it is always best done when prior to the induction of patient. So it is the best timing to do the to assess the diastolic dysfunction. So what are the various things we look into? That is transmitral inflow. If you see the transmitral inflow, you can see two waves, that is peak E wave and A wave, and phase of diastasis in between. Apart from that, you have other things like isovolumetric relaxation time, that is the rate of LV relaxation, and LAP. E wave, which is a driving force between LA and LV. Deceleration time is the time of pressure equalization between LA and LV, and A wave is because of the atrial contractility. A wave duration is important to assess the LV filling pressures, and finally L wave, that is diastasis, when it is seen whenever the heart rate is too low because of blood from pulmonary veins flowing into LA and LV. So the normal values of E wave, normally E wave is taller than A wave, and E wave normal values ranges from 50 to 80 centimeters per second. A wave normal values ranges from 30 to 50 centimeters per second, whereas the E by ratio is normally between 1 to 2 is to 1. The deceleration time of E wave is normally between 140 to 240 milliseconds, and the isovolumetric relaxation time is between 60 to 90 milliseconds. What are the technical recommendations for this? So basically it is done with a pulse wave Doppler in mid-esophageal 4-chamber view. The alignment with a near zero angle to the AV inflow is required, because even a 20 degrees there is 6% error, and the sample volume should be ideally 1.5 to 2 mm. The sample volume should be placed at mitral leaflet tips. Except when we are specifically measuring the A duration, where it can be placed near the annulus. So, but whenever you do this mistake of not placing near the tips, by moving from annulus to tips, you can see that there is an increase in E velocity and decreased in deceleration time. So the sweeps speed should be maintained at 50 to 100, and then average of 3 beats should be taken, and ideally it should be done at end expiration. So if you see normal phase, stage 1, stage 2 and stage 3 of diastolic dysfunction, you can see normal pattern E wave is more than A wave, whereas in phase 1, where there is an impaired relaxation, the E wave looks smaller than A1, but there is an increased in deceleration time. Coming to stage 2, here this picture is similar to the normal phase. The E wave is greater than A, and the deceleration time is also more than 140 milliseconds. But how do you differentiate the pseudo normal phase from the normal phase? That I'll be telling you now, based on various parameters. First, clinically, see, for example, if the patient has an age of more than 70 years with hypertrophic of ischemic cardiomyopathy, with a E by A between 0.75 to 1.5, always consider it as a pseudo normal, and do the other parameters to confirm it. And then whenever there is a 2D echocardiography evidence of LV remodeling, that is hypertrophy, dilatation, scars present, always consider it. And whenever there is a 2D echocardiography evidence of LA pressure elevation, LA enlargement with the history of atrial fibrillation or mitral valve disease, in them also you have to differentiate. So how do you do it? As we told once, when we are reducing the preload through some dynamic maneuvers like Valsalva maneuvers, it will unmask this mitral inflow pattern from pseudo normal phase to the impaired relaxation phase, that is from stage 2 to stage 1. If that is not happening, then you can consider it as a normal diastolic dysfunction. And apart from that, there are other parameters which we'll be discussing, which can be helpful to differentiate this pseudo normal phase from the normal phase, that is propagation velocity, and even in fact the tissue Doppler imaging, where there is a constant decrease in E prime velocity throughout all stages, even right from stage 1 to stage 3, but it is normal in stage that is 0. So what are the limitations? Basically, increased, whenever the patient with increased afterload, you cannot do it because there is decreased E velocity and increased deceleration time. In patients with tachycardia, there is a fusion of E and A wave, so there also it is difficult to check this parameter. And atrial fibrillation, where A wave is absent, and in mitral stenosis, due to calcification and other things, there's there's a fusion of E and A wave also. So all these things. In MR, there is increase in left atrial pressure, so it mimics the restrictive pattern, but ultimately in this subset you need to measure A duration, which is a better gives a better predictive value. So next, coming to the isovolumetric relaxation part, it can be either assessed by transgastric long axis view with a pulse wave sample volume placed between mitral inflow and LVOT. It can be assessed by like that, or by a tissue Doppler imaging from the lateral mitral annulus. We can measure this isovolumetric relaxation time. So basically the normal value is 60 to 90 milliseconds. Initially, in the initial phases of impaired relaxation, it is prolonged, but as this grade increases, the restrictive filling occurs, then there is a shortening of isovolumetric relaxation time. So as you can see, the figure in the left shows that the isovolumetric relaxation time is between E wave and the closure of the aortic this thing, and whereas in the tissue Doppler, or the image on the right, shows you that the isovolumetric relaxation time is between the S wave and E prime. So, and coming to the third parameter, that is mitral annulus tissue Doppler imaging. So basically we have the following waves here. One is the S wave, which in transesophageal echo is below the baseline. It indicates the descent of mitral annulus towards the apex. E prime is an early diastole, it is present above the baseline and it indicates the active relaxation. A prime is the late diastole, and isovolumetric relaxation time, as we discussed, it is between the S prime and E prime. So apart from that, there are some derived parameters which help in grading the diastolic dysfunction, that is E by E prime, which is a better predictor of always correlates with LV filling, and even the time difference between E prime and E. And apart from that, there is another parameter called isovolumetric relaxation time by time difference between E prime and E. These are all the derived parameters which can be used to basically grade the diastolic dysfunction. So E prime value, basically normal value septal, it is around 10, and lateral values it is around 13 centimeters per second. So whenever the septal value is less than 7 and the lateral value is less than 9 to 10, then it indicates abnormal relaxation. Then A prime value, the normal value is around 11.3. It increases with increased LA contractility and decreases with increased left ventricular end diastolic pressure. Now, what are the technical recommendations? Tissue Doppler measures high amplitude, low velocities of myocardium with either color or spectral Doppler. So in mid-esophageal 4-chamber view, you can take a pulse wave Doppler sample which is around 2.5 to 5 mm in either the septal or the lateral annulus within 1 centimeter of the junction of the mitral leaflet with the wall. So lateral annulus is preferred because the velocities are higher, more reproducible, and it is less influenced by the blood flow velocities. So apart from that, we have to keep the gain and filters minimum and sweep speed at around 100 to 200 millimeters per second. So what are the advantages of this tissue Doppler? E prime, it is obviously very less preload dependent than E, and E by E prime, it is a very good parameter which correlates with the LV filling, and it can detect even early rejection in transplant patient. It is this E and E prime can differentiate even the different kinds of pericard, like constrictive pericarditis or restrictive cardiomyopathy also. So what are the limitations? E prime does not predict the relaxation in basal wall motion abnormality. Here the average of septal and lateral E prime is always better. Septal E prime, as we told, it is affected by right heart pathology or pulmonary hypertension. And this tissue Doppler imaging definitely is not useful in case of mitral valvular calcification, and whenever there is an annuloplasty, or even in patients post mitral valve replacement. So if you broadly see this two aspects of here, first, in the first figure, we can see the mitral inflow velocities. In normal patients, for example, to differentiate between the stage 2 and that is pseudo-normal and normal phase, if you decrease the preload, there is, in normal patient, there is decreased in E and A velocity, so there is no decrease in E by A ratio. Whereas in patients with diastolic dysfunction, there is decreased in E velocity and without much decrease in A velocity. So moving it to stage 1, that is impaired relaxation phase, and thereby decreasing the E by A ratio. And now coming to the tissue Doppler imaging, you can see in tissue Doppler imaging, the E by A ratio in normal patient is greater than 1, and E prime is always occurs earlier than E. But whereas in diastolic dysfunction, E prime velocity decreases continuously, and E prime by A prime ratio is less than 1 in all phases of the diastolic dysfunction. So as I told, filling pressures can be assessed by E by E prime ratio, which is gradually increased along the stages of the diastolic dysfunction. And apart from that, time difference between E prime and E can be used as a parameter to assess LV relaxation and LV filling pressure. So coming to the fourth aspect, that is pulmonary venous flow. Here basically we have an S wave, S1 and S2, which is seen in early and late systole, and D wave which occurs in the early diastole. These are seen above the baseline, and whereas the AR wave, which is due to the retrograde flow from LA to pulmonary veins or during the atrial kick, is the wave which is seen below the baseline. So this AR wave, AR duration is age independent parameter, and the time difference between the AR duration and A duration also correlates well with the stages of diastolic dysfunction. And apart from that, you have some other derived parameters also through venous flow, pulmonary venous flow. So what are the technical recommendations? Yes, right in esophageal echo, right upper pulmonary vein cannot be assessed because it runs in anterior posterior direction, so making an angle of more than 90, so it is very difficult. So ideally in mid esophageal 4-chamber view, we slightly withdraw and turn the probe towards the left, and at around 30 to 60 degrees we can see the left upper pulmonary vein. The right upper pulmonary vein can be assessed in another view, that is modified bicaval view, at around 110 to 130 degrees. The pulse wave sample should be placed at 1 to 2 centimeters inside into the pulmonary valve, and the sample volume of 2 to 5 mm, sweep speed of about 50 to 100 millimeters per second, and take an average of 3 beats at end expiration. So what are the limitations? There is in young patient there is blunting of S, in tachycardia there is blunting of D, in atrial fibrillation there is absent of AR and in mitral stenosis there is decreased in S, D and AR. Whereas in mitral regurgitation there is decreased in S2 and D velocity, whereas D velocity increases. So now if you see the trend, the normal patient once they are going into stage 1 diastolic dysfunction, you can see the S wave is more than D wave, and then subsequently the S wave becomes less than D wave as the diastolic dysfunction stage progresses. And you can see initially the A duration in normal patients and in impaired relaxation, the A duration is more than the AR duration, but subsequently as the stage of diastolic dysfunction increases, the AR duration is more than A duration by 30 milliseconds. So this is also very important. So as we can see, the distribution of these various echo parameters has a typical U shape in this assessing the diastolic dysfunction. See, you can see the E and the E by A ratio. Initially it is increased, and initially at stage 1 it is decreased, and then finally as going into stage 2 and 3 it is further increased. And the opposite pattern is seen in deceleration time, or in isovolumetric relaxation time, or S by D ratio. But here you can see that the only E prime parameters constantly decreases in patients from normal phase to severe diastolic dysfunction. And a similar thing happens with the propagation velocity also, which we'll be discussing now. So propagation velocity, it is basically assesses the LV suction during early diastole and better evaluates the LV relaxation compared to the single point measurements. So here in mid-esophageal 4-chamber view, color Doppler position the M-mode scan line to the center of the LV inflow blood column from mitral valve to apex, and shift the Nyquist limit to less than 40, and velocity of propagation is as the first aliasing velocity slope in early filling from mitral valve to up to 4 centimeter into the LV, and the transition slope from no color to color has to be seen. So ideally the normal values is more than 50 centimeters per second, but as the stage of diastolic dysfunction increases, this value comes down. So the other parameter which we would assess is the LA size. LA size is an independent predictor of adverse outcome in patients with AF, heart failure, stroke and death. LA size estimation estimates the degree of diastolic dysfunction. Indexed LA volume correlates with the grade of diastolic dysfunction. Greater than 34 ml per meter square is considered significant. What are the technical recommendations? TE, yes, it is slightly difficult to measure because the superior border is missing. Now the transgastric views are used to assess the LA size. Other than that, you can take a TTE view in end ventricular systole. Do not include the left atrial appendage in mid-esophageal 4-chamber and 2-chamber view. And next, recently the 3D COI is coming up, where the LA volumetric analysis and LAEF can be calculated, which also is a very good parameter which could grade the diastolic dysfunction. And then now the strain imaging, the global strain image, that is the strain rate of isovolumetric relaxation, strain rate of EA can all assess the diastolic dysfunction. And now the single important parameter which is coming up is LA strain. It is observed that the LA strain as a single parameter, since now till now we have seen many parameters as a clubbed thing to assess the diastolic dysfunction, but LA strain as a single parameter is known to assess the severity of the diastolic dysfunction. It has been observed in a study by Asing et al. That LA strain changes progressively with severity of diastolic dysfunction, and by a study done by Freitas et al. Showed that LA strain helped in evaluation of diastolic dysfunction in patients with heart failure and sinus rhythm irrespective of left ventricular ejection fraction. So basically, if you see the strain wave pattern, there is 3 phases. First is the reservoir phase, the next is the conduit phase, and next is the booster pump function. So ideally, the normal value is around 40%. As we see this image on towards the right, that is a study done by Asing et al. Shows that this peak is constantly coming down along the stages of along the grades of the diastolic dysfunction. So this progressively changing with the severity of diastolic dysfunction. So since we have seen multiple parameters and seen the characteristic U-shaped distribution of those parameters, so we have many proposed algorithms, but a recent algorithm proposed by J et al. Is a very simple assessment of diastolic dysfunction. So in all patients except for those with moderate MAC, LBBB, paced rhythms and severe primary pulmonary hypertension, we assess four important parameters, that is septal E prime velocity, E by E prime, TR velocity and LA volume index. So the normal values for septal E prime is more than 7, E by E prime is less than 15, TR velocity is less than 2.5 and LA volume index should be less than 3 ml per meter square. So in these four parameters, if 3 are normal, then it indicates normal filling pressures. So the patient can be either having normal diastolic function or can be in grade 1 diastolic function. If 3 are abnormal, then the patient is having increased filling pressures. So he can be categorized further by assessing into grade 2 or grade 3 diastolic dysfunction. But whenever there is 2 normal and 2 abnormal, and this is the indeterminate picture where we have to take help of the other parameters like IVRT, considering a Valsalva maneuver or an LA strain, all these things, and further assessments to grade the diastolic dysfunction. So diagnosis, and apart from echo, we have various other modalities to assess and to diagnose and evaluate the diastolic dysfunction, which includes X-rays, stress test, ECG, proper ECG, MRI, nuclear imaging, cardiac catheterization, PET scans, all these things. And now coming to the perioperative aspects, so what all things we have to consider during the perioperative period, that is the risk factors. We have to consider the risk factors like age, female, hypertensive, ischemic heart disease, diabetes, obesity, patients with COPD, and the other important thing which is coming up significantly is patients with obstructive sleep apnea mostly will have an underlying diastolic dysfunction, so those patients should be thoroughly evaluated. So whenever there is acute decompensated diastolic heart failure in the perioperative period, the base things should be reduce the pulmonary congestion, correction of other precipitating factors like hypertension crisis, MI, acute rhythm disturbances or sepsis. So what are the goals? Prevent development of diastolic heart failure by decreasing the risk factors, allow adequate filling time for left ventricle by decreasing the heart rate, controlled volume overload, that is important, and then restore and maintain sinus rhythm, decrease ventricular remodeling and correct the other precipitating factors. So what are the various management strategies? Treat the coronary artery disease, treat hypertension, control weight gain, treatment of diabetes mellitus, using drugs, rate limiting drugs like beta blockers, calcium channel blockers, diuretics. Yes, you have to be using it very carefully. Apart from that, long acting nitrates, consumption of low sodium diet can all be the management strategies. Apart from that, cardioversion, amiodarone, AC enzyme inhibitors play a very big role, and apart from that, newer drugs like RAS axis blockers, ennodonors, and other agents targeting the actin myosin cross bridges are coming up. So other device or surgeries which can be used is revascularization procedures as PCI or a CABG, valvular surgery, CRT or ICD placement, VAD placement, and finally heart transplantation. So what are the factors in the perioperative period which will trigger this diastolic dysfunction or leading to diastolic heart failure? That is, one is shivering, anemia, hypoxia, electrolyte imbalance, myocardial ischemia, hypervolemia, tachycardia, rhythms other than sinus rhythm, post-operative sympathetic stimulation, post-operative hypertension crisis. So these all aspects has to be kept in mind. So what are the goals? What are the goals or the take-home points in managing this diastolic dysfunction? First, establish preoperatively its dominance in echo, whether it's systolic heart failure or diastolic dysfunction, or it's a combined dysfunction. You have to assess them pre-operatively. And then maintain sinus rhythm and avoid tachycardia. Always use rate control drugs. Always avoid pain. Keep the patient deeply sedated. All these things are very important. And apart from that, AV, if patient requires an pacing, AV sequential pacing is very useful in such patients. And then always prevent and treat myocardial ischemia. Avoid rise in afterload, and then ensure sufficient preload and avoid volume overload. Keep them adequately filled, and then reduction of pulmonary congestion and peripheral edema with diuretics, but avoid severe diuresis in them. And then then improve the LV diastolic distensibility by lucitropic agents like dobutamine, levosimendan, milrinone. All play an important role in the perioperative period. So these are the references. Most of my images, echo images, are from the perioperative two-dimensional echocardiography by Anat Vegas, and apart from that, the other references I have mentioned here. Thank you so much.